Well, that was not files. Your email. Let me see that. Yeah, I also that's it.
So,
Any which one? One, two, well. Well, I would recommend that you. Okay. Very, very awesome. You said the Zoom is the fourth scan, I switched the last to the last.
a couple spots just opened up, so,
Oh, good. Yeah, she's gonna move the car.
yeah. Who was moving it?
No, I think
Oh,
it's an extra spot there.
you know what we need to do is we have to put that sandwich board up like 2 hours before our event,
Yeah.
so that people don't park
They
here.
can schedule things on Wednesdays. but-
Yeah.
Does that have the time on it?
Once I hit play,
It
yeah,
does.
do a timer.
Do you know how many people were out there looking for spots?
I saw one car driving around, but
Okay. Do you want to just speak?
yeah, how many we have on Zoom? 5, okay.
We'll give it a minute.
Go, you can go. I'll hit play here. Okay, we'll get going. Thank you guys for coming. My name is Gigi Weiss. I'm the Senior Director here at RDNA Health. I'm a physical therapist, and I oversee all the rehab in the community. And I'll have Danielle
Here we are.
introduce herself.
Hi,
I've been
I'm
here, I've
Danielle.
been here about almost 15 years.
Yeah.
So we're
Yeah.
excited to have this program.
Hi, I'm Danielle Taibbi. I'm an occupational therapist by trade. I've been at RDNA for about 8 years, treating, but I've also supervised in the private department, educating private aides and doing care plans for people that need private care in their homes. I am now back treating again in various facilities and homes, and we're doing an education program for our staff, meaning our nurses, our therapists, our CNAs, our private aides, to get them all dementia certified. So the goal of the agency is to have as many people certified as possible who are going out into the community, because we're just seeing such a huge boom in the need for caregivers who really know strategies and interventions for this illness that we're now dealing with more and more. So
And both Danielle and I are certified dementia practitioners as well as certified dementia care trainers. So we're the ones that train our staff.
and staff at other
And
facilities.
staff at other facilities and
So we'll be going into one of the assisted livings in Wilton, and we're taking about 20 of their staff members and training them.
it is. Just a quick thing for those that are not familiar with RVNA Health. We are a home health agency that started in 1914. We have a continuum of care that encompasses our Be Well as our community health and wellness, our Get Well as our home health department, and Staying Well is our private pay service, and Comfort Well is our hospice care. So we kind of do it all. So just want to give you a little update that we are a nonprofit, and we're able to do programs like this because of donations and grants that we get.
Has anyone here used our services for themselves or a family member? You have, okay. Two of you, okay, great.
My
And-
mom and my mom.
Okay, and how did the others in the room hear about us?
I think, somebody recommended, referred me to, the call.
Wonderful,
Great.
okay,
That's how I got it, was,
Yeah, so we,
worker.
yeah, we service all Fairfield County from Greenwich to Litchfield, so over 38 towns in kind of western Connecticut, so. If you need something, we could probably provide for you.
and because there's not too many people in the room, we will hold most of the questions for the end of the presentation. But we do like to get an idea at the start of the presentation, what you're expecting to learn today or what you're hoping to learn today or get out of this presentation.
I,
Start with you and go around. Yeah.
my wife was just diagnosed with dementia.
I'm
So
sorry.
I have no idea, how do I talk to them because I'm the caregiver, so to speak.
Mhm.
It's kind of difficult because I'm the husband, the way they talk, it's not like if maybe this young lady would talk to her, she may listen. To me, she's not going to. So I'm trying to want to get some knowledge and how do I, to a point, I know eventually what's going to happen, but I just need to know
Mhm.
how to talk to them if I have to walk away or do this or some way, some form. I'm
Yeah.
gonna stay ahead. I guess they want to stay ahead of the game, so to speak, which I can't, but I'm trying.
Gotcha, good. We cover a lot of those strategies that you just mentioned for agitation, for people that are in the denying stages, especially early on. So we will talk about that. You?
I have been trained by the Alzheimer's Association,
Wonderful.
and I think you'll never know everything.
Right.
So I think the more one reinforces the knowledge, the better.
Yeah, great.
Hi.
Hi.
My husband's been diagnosed with MCI. So we're early, but it's progressing rather quickly. So I'm just trying to get ahead
Great.
to educate myself.
Nora, why are you here?
I'm the patient experience manager here at RVNA. My name is Nora, and I'm just coming to see what's happening and how we're helping the community and just to see, be in touch with all the things that we're doing.
MJ?
I'm MJ Heller and I'm the Director of Philanthropy. So I raise money to offset the costs of classes like this, but I'm here on a personal level because I care for an older brother who has frontotemporal dementia. So it impacts at a very, very, very young age. He's, seriously ill with dementia and is only 63 years old. So
There's a good website.
Hmm.
There's a very good website from the Frontal Dementia Organization.
I've been on it.
And yeah.
Yeah.
My mother has had dementia. She died. It was diagnosed as Parkinson's.
Alzheimer's?
Alzheimer's.
Mhm.
And I've been having cognitive issues as we go along. And I also have neighbors of MJ. So,
Yeah.
and anyway, so I'm here to see how I can help myself.
Awesome, yeah. Thanks. So we always feel like we learn as much as you guys do when we host these. So at the end, we definitely have an opportunity to kind of open it up and talk. But if I'm going too fast or you can't hear us, please let us know. Or if you need something restated.
In this series, we're really talking about communication. And we've had some previous series where we kind of did like dementia 101 with all the stages, which we'll touch a little bit on, but just so you know, we're kind of really focusing on the
And we did
communication.
record those and
piece.
they are on YouTube, so if anybody.
Yeah, for those that are new to the room.
Okay, the dementia playlist. So kind of defining dementia, it's not a specific disease, right? It's people, it's the D, I call it the D word now because people are really scared of the word dementia, but they also don't seem to really know what it means. So it's not a specific disease, but a general term for the impaired ability to remember, think, or make decisions. So it really is an umbrella term for symptoms. Okay. And Alzheimer's, the reason people confuse it is because Alzheimer's is the most common type of dementia. There are 19 probably plus different types or reasons that people develop dementias. These are some of the other common ones. And the reason I would like to highlight those is because when we think about the population that has dementia, we often think that it's a women's disease, right? Why? Because we think that so many more women have it than males, but not really. It's just the Alzheimer's is more common in women. But these other categories, some of these are actually more populated by men. So it's a bit of a misconception that it hits females more than males. But why else would it hit females more than males, would you think, in the long run when we're looking at this?
They live longer.
They live longer. Okay. They used to say less stressors, less strife, because they were working or doing as much as men. So that's really out the window, right? We're not looking at that for the reasoning anymore. But it really is, we still are outliving men. So that's why we see it in larger numbers. So the loss of cognitive function in these areas. So we always think of it as just memory loss. And then somebody tells me, well, I keep losing something. I keep losing my keys, or I keep losing my wallet. You know, does this mean that I've got dementia? Well, really, there's other things that you need to consider when you're looking at, hey, should I be concerned about what's going on with me? And language skills, visual perception, focus and attention, comprehension, and judgment are also areas that get affected. So we always just think of memory, but it really starts to affect all of these, which is why we're going to talk about how to communicate with people at different levels of dementia.
And just know when they're diagnosing someone with dementia, it's really a cluster of symptoms, right? It's not just the one, like it's all of these things in conjunction that kind of, you know, that there's a loss of function that kind of gets the diagnosis of dementia.
And there are other things that might cause memory loss. Right? I can tell you I lose my keys. When I'm anxious, I lose everything. So anxiety can cause people to lose things, right? Being stressed out, having too many things on your plate, your mind is in too many different places. So it doesn't always mean that you have mild cognitive impairment or that you're going to go on to have dementia. Okay, one of the red flags might be if your short-term memory is starting to go, or you listen to somebody and their short-term memory seems to be impaired, but they're talking in very detailed manner about their past, as if they're right there in the moment in the year 1945, for example. And that repetitiveness where they keep going back to that same story, those are more red flags than just quote unquote memory loss or losing keys or forgetting what you had for breakfast 2 days ago. Those are going to be more important to look at. So the reason we wanted to go through some of the stages is because when you have an idea, and these are not black and white, but this kind of breaks it down in a way that you can look at the person that you're working with and say, okay, they're kind of in this early stage. You know, stage 1 is no cognitive decline. So it's kind of like something's brewing here. Stage 2, we're in that mild cognitive decline. And it's important to know that because that's when you want to start thinking, hey, is something going on? And yes, it may just be mild cognitive impairment and it may stop there, but it may continue on to one of these other stages. And the reason you want to know here is because that's when you can have important conversations like, Mom, I notice you're starting to lose your memory. We've never really had to talk about your wants and desires. What happens if you do lose your memory and your judgment skills, etc.? What do you want for yourself? You can't really be having that discussion here, right? So it's important to have it when you're first starting to see things, okay? By stage 3, you know, this is getting where a little more serious, where you're starting to notice that people become defensive. So if you know, you just said you have somebody that's newly diagnosed, and by the way you were talking, I got the impression that maybe there's some defensiveness. Yes. There's a term we call masking also, which is denying or making excuses for losing things or forgetting things, or trying to hide the fact that they have early symptoms, because people are aware and it's very scary in the beginning.
That's the point. It's like they are aware, but they're denying it, and they'll,
Mhm.
what's the word? It's a word I would flip it, so to speak, to say that it's not them, it's the other person trying to, like, I'm trying to communicate.
Yep,
And she says this, it's me.
right.
So
She's
that's.
gaslighting you. That's like the
Yeah, I mean, I don't know
2024
about
word
those
for that.
details.
Right.
That's my daughter. That's
But
just-
yeah, it's trying to flip the blame or blame it on things other than their own loss of cognition, because it's a really heavy and hard thing to admit, right?
Yes.
Depression.
Yes. And we'll talk about how that kind of goes hand in hand with dementia as well. But it's very common to see people get defensive. So you're not alone. And that is something we expect to see kind of in those early stages. The other thing we see is that people in social settings become the person kind of outside the group. So everybody's talking and you might notice your loved one is kind of nodding along and faking it, because that's probably what they're doing, because those conversations now are too fast for them to pick up on everything. So they might stand a little bit outside the conversation. And when you really direct something at them, you might realize that, oh, wait, mom is not understanding this. She's just kind of nodding along. And that realization is important, because when people get to that point of dementia, they start to pull back and isolate themselves, because it's easier not to put themselves in a situation where they'll be found out or where they're going to feel embarrassed because they can't keep up with conversations people are having socially. Okay. We'll talk about the more severe stages later, but again, knowing that their stages help us match activities and communication styles. So in the beginning of dementia, there's certain strategies you're going to incorporate that you're not at stage 6 or 7. Because when you get to stage 6 or 7, what usually happens with communication? The person oftentimes becomes nonverbal, or there's very limited speech or nonsensical speech. So it's going to be very different when you're working with somebody in those later stages than in the beginning stages. In the beginning stages, you're going to be validating a lot. You're going to be soothing a lot. Your patience is really going to be tested because it's really difficult to stay calm when somebody's accusing you of something. But in the early stages, those are the most important things. You want to validate people, and you want to hold on to your empathy and realize that that person is realizing themselves that they potentially have a very profound disease progression starting. Okay. So if we look at it that way, I think we'll approach people differently when we talk to them.
So next, we're going to just kind of talk about, what to remember when you're interacting with someone who's in, earlier stages or even later stages. It's really important, especially in the early stages, to include that person in the conversation. You don't want to be at a doctor's appointment and have someone, that you're not addressing, right? It's your mom there, or your wife is there. You want to make sure that you're including them in all those conversations, because they might be confused, but they understand. It's also important that, they're going to have times of clarity, and then they're going to have times where they're confused. They might not have remembered yesterday. So just be aware of that. Learning new information. This is that front temporal lobe. They're not going to have that ability to kind of take in new information. So those long terms, like Danielle said, those long-term memories will always be there. They're stored so deep in the brain that even in the end stages of dementia, they might have some clarity from really long-term memory. So just know that if you're asking someone to kind of learn something new, even in the early or middle stages of dementia, is very difficult. They have it's mostly in the end stages, later stages, they're really living in the present moment, right? So just kind of remember that. And also remember, they haven't lost their problem solving skills. Those are the people that figure out how to, get away from, if they're in a locked unit or if they're in an assisted living that's locked, they figure out how to get out. They are able to disguise their symptoms and pretend like they're, we've had a case that she, put a purse on her back and someone let her out because she just presented herself in such a way. And so then
She was a family
she
member,
thought they was a family member. So
and she was younger,
yeah,
so she
So,
fooled everyone.
they fooled everyone. So, they don't lose their problem solving skills. So if they want to leave, that they will figure it out.
I had one woman completely dismantle her window in her bedroom and literally jump out the window. When I say jump, it wasn't like she stepped out onto ground. She actually jumped about 7 feet down to the ground from her window. So people, when they're in the wandering stage or that fear stage or paranoia, and it can happen even in their own home, right? Especially if people introduce new caregivers or new routines, et cetera, or they feel like things are being taken away from them, like they're not allowed to drive. That's when we start seeing those kind of behaviors that we have to watch out for, where they try to get away.
And this is just a really important thing to remember, especially as through the middle to later stages. Really important to live in their reality, live their truth. You want to validate the gone are the days of trying to reorient, right? You don't. There were times where you would write on the board, today is Wednesday, May 9th, right? And you would keep trying to reorient. Those days are gone. So if someone thinks that it is 1942 and they're in a happy place, you go along with it. You want to validate those feelings and their thoughts. There's nothing wrong with it, and that's really a kind of a newer
Approach. I think
approach.
in the early stages, I get asked this a lot. In the earlier stages, do you want to keep calendars, clocks, etc.? Yes, you can use strategies. If the person can still use strategies, you can use those types of things to help them keep organized, especially with like mild cognitive impairment. Those kind of strategies work. But once a person cannot use strategies, there's no point to a memory book, because now they're forgetting to write things down in that notebook, right? Or maybe at a certain point, they can't even read the clock. Or if they look at the calendar and they see, oh, it's May 9th, that doesn't mean anything to them anymore. They're not connecting the dots anymore. So those strategies, maybe very early on, could be helpful, memory strategies, but later on, we're kind of just, we're letting people be where they are, and we're entering their world, especially in the mid to late stages. So if I enter a room and Mrs. Smith says to me, Danielle, I had a terrible night. And I need to find my wallet because last night somebody came in and stole my wallet. What people want to do is say, Mrs. Smith, your wallet is in the other room. It's stored where we always store it. It's right there. So that's not validating. That's actually saying you're wrong, you're crazy, and this is all in your head. So how do you think that response is going to make that person feel? Right. Angry, agitated, upset, embarrassed, devalued. So what we would do in that situation, and yeah, it's white lying, but what you do in that situation is say, you know what, Mrs. Smith, I'm really sorry that happened, and I will report it to the head nurse. And in the meantime, why don't you and let's walk around and see if maybe somebody misplaced it. I hope that's what happened and that it wasn't stolen, but you might be right and it might have been stolen. And you go and you take them into another room and you look around for it for a second, and what happens? They forget what they're looking for. They forget that they've even told you a wallet was stolen, right? Because a couple minutes later, they're having a memory lapse and not remembering that moment. And then you can redirect them. So once they've forgotten what they were upset about, you can say, hey, look at this beautiful picture of you and your husband. I never noticed that picture before. Tell me about it. And then you've got them onto a happy memory or something that they can talk about and feel confident about. So first you have to validate, and then you redirect. If you try to just redirect, they're going to be onto that. And I've made that mistake a million times, where somebody will say something to me and it's clearly not the truth, and it's clearly some delusion or paranoia that they're having. And I'll say, hey, look over there at this. And it doesn't work because that person hasn't forgotten yet. And they're in the moment and they think you're just ignoring them. Does that make sense? The difference of validate first, then redirect. Okay,
I have just one question. I had an incident where a person says, I came in the house, I know I had my pocketbook, I know what's in the house. So, okay, I said, okay, it's in the house, what would you like me to do? I said, I don't mind helping looking for it, if you let me go in your room. You know what? Yeah, you can go in there, so I went in there.
Mhm.
I said, there you go. I didn't say anything more. I mean, I made plenty of mistakes before that, but I asked them what they want. I don't know if that's the right way to go, but that's what I did.
Yeah, I think you validated them. I think you didn't say, no, it's here, you're being. It's, it's let me help you. It's always a let me help you, or I'm so sorry that happened. Those are ways to get people to go from, up here to down here. So what you're trying to do is you're trying to take them down a notch, because every little thing causes what we call a catastrophic reaction. So if somebody lost their keys for a few minutes and they're not in a huge rush, right? Okay, this might upset you, but the person that has cognitive loss or beginnings of dementia is going to react up here. Oh my God, it's the end of the world. And they might even start making up stories about what happened to those keys, et cetera. And it becomes a much bigger thing than what actually happened. So you have to keep that in mind. So your goal as a caregiver is to bring them down, to say, it's okay, I'm going to help you with this, we're going to figure it out, and validate their feelings.
So this is just to kind of go along with what Danielle said about what, if we don't validate, the patient feels that anger, that distrust, they're suspicious. So those are just the, natural feelings. So how important it is to go through the validation. So Naomi Feil is the founder of this validation training institute. She actually just passed away in December or January of this year. She started she's a social worker, and she was really the one that came and changed the way we communicate with people with dementia. She was the one that used all her experience and came up with the validation and kind of got away with the reorientation concept. So she really is what they call the godmother of person-centered care. She wrote many books. So if you're really looking on how to do communication with patients, she's really the pioneer in the validation method and how it really works with people with dementia. Other things to remember when we're interacting with people is it's really important to be a detective, right? Because they are trying to express something to you that they can't get out, and you're trying to figure it out. So it's really important to kind of learn to listen as best you can, observe what they're trying to say, and really take that time and be patient and trying to figure out, because there's frustrations on both ends, and kind of begin with as in later stages, if they're not unable to express their personal needs. And a lot of times people are just trying to tell you they're, just kind of begin with those personal things. They have to go to the bathroom, or maybe they're hungry, or maybe they're thirsty. So, kind of work on beginning those basic needs. And it's just about developing a trust, right? When you're and trying not to keep asking repetitive questions. Anything else you wanted to say?
Sorry, and also learning how to respond to repetitive questions.
Yeah.
So what's going to happen is that person with dementia is going to keep asking you the same question. That's very hard and very frustrating for people. Know that they don't realize that they're repetitively asking it. It's partly a perseveration, but it's also they're forgetting that they asked it in the first place. So there's a couple different things going on. And you don't want to let them know that you're getting frustrated or annoyed with their questioning. Just answer calmly. And I do want to say something as I'm talking. This sounds very easy for me to say. As a family member and as somebody that's living with it all the time, these are not easy strategies. We are not suggesting that a million mistakes aren't going to be made. And I would say, especially for you who has somebody newly diagnosed, it's okay, you're gonna make a million mistakes. I've been doing this a long time and I still walk into a room and say, hey, do you remember me? And I'm like, oh, no, they don't remember me. Let me try that again, you know, so you're gonna have to kind of catch yourself doing things and reset and say, okay, that's not how we approach somebody, right? We go in and we pretend it's the first time they're seeing us, but we try to make them comfortable so that there's something about us that they feel a trust with, so that they're willing to work with us, and again, bring down that potential agitation to a level of calm, okay?
One of the things you mentioned a while back was about processing, you know, like when you keep asking them questions, you actually have to wait much
Yeah.
longer than you would anticipate for them to respond because it's taking them a while to really hear what.
It could take up to 90 seconds or, you know, for someone to answer even a simple yes or no kind of question, and to have the patience to sit there and try to get, you know, to wait for that, it's hard.
Yeah.
But yes, just know that the processing time, it is much slower.
So what'll happen is if you ask dad something and dad doesn't answer right away, people will make the assumption, oh, he doesn't understand. He's not getting this conversation, or he's too far gone or whatnot. And really what could be going on is that he is still processing what you've said. And if you give him that time, you might find out he understands 100% what you're saying. He just needed that time to not only process it, but then to come up with a response. Because remember, the word finding is also an issue, right? So that's all going to take time. We talked a lot about validating, which we're gonna give you some examples of how to do that as we go along. But really what we're trying to reduce is isolation, depression, loneliness. So when you start to see somebody kind of pulling back, that's when you want to set up social situations that might feel a little bit safer. So instead of going to a party where, you know, they're going to have to socialize with a whole room full of people, maybe you go out with two of your best friends to a quiet place for a cup of coffee. So set the person up for success in terms of social outings, because you don't want to put them in a situation where they're going to want to do less and less of that, because then you're going to get isolation, depression, loneliness. Power struggles are the biggest thing that I see. And we talked about what catastrophic behaviors are. That means a really big response to something that maybe it wasn't appropriate to respond that way to, but now we expect that kind of response. The power struggles that I see are not just with families. I have to tell you, I see it at assisted livings. I see it with private aides. I see it with friends that are not family members. People want to correct people. And it is the biggest mistake we can make with working with this population. You cannot try to correct people, because then you're going to get into a power struggle and the gaslighting that you were talking about, where, you know, the blame game starts to happen. So you want to diffuse that power struggle and think to yourself, in these situations, my wife is always right. From now on, she is always right. Okay, so what she says to you, I hear you, honey. Even if it's wrong, I hear you.
And that's how we keep peace.
Right? I hear you.
That's what I've been now. Just what she says is, okay,
Yeah.
disagree, okay, okay, okay.
Mhm.
And then it seems to,
Calm her down.
yeah. And I just leave it alone and.
And there's nothing that says, you know, I think why I call it the D word is too, because people try to stay away from talking about the elephant in the room. It's okay to say to her, I'm really sorry that you're feeling this way. I know this is really scary for you. That will register with somebody.
Okay.
You know, you don't have to necessarily say your dementia is, you know, but you can say, I understand that things have been confusing for you and I'm sorry. And any way that I can help you, I'm here for you. And it's really hard to do that after a while. And if you need a break from it, you have to be honest with yourself and say, you know what? I need to walk away, or I need to have somebody else be with my wife for a day, because I'm getting to a place where I can't be that person. And that's fair. That's more than fair, right? So promote bonding between the person and the caregiver. So you're not going to get somebody to shower if you're constantly having a power struggle. So I have to a lot of times say to caregivers, aides, You know, you can't go into Mrs. Jones' room and say, let's go, you're getting in the shower. I got 8 patients, let's go. We're going in the shower, let's go. If you come in with that kind of approach, you're not gonna win. You're just not gonna win. And yes, you are supposed to tell, not ask. What that means is, if I go in and I say, Mrs. Jones, would you like to shower today? What's the answer?
No.
All right, see you later. You know, that's what's gonna happen. But if you go in and you say, how's it going today? You look great. I love that shirt on you. And you start to establish and you start to use some body language that brings you down a little bit. Eye contact, try to get them to look in your eyes and trust you. That is the kind of relationship where somebody then might let you shower them. Maybe not today, maybe my next session. And maybe today we're just going to walk to the bathroom together. You know, maybe I'm going to actually paint Mrs. Jones's nails and make her feel like we've done something around hygiene or appearance, etc., that's safe to her. And then I can move it into different territory when she trusts me enough. You know what? We're going to get in the shower today and you're going to feel great. And I'm not going to let you get pulled. Because why do a lot of people not want to shower? And they can't tell you that. A lot of times they don't know that that's why they don't like it. Also, sensory things feel much different. So you know how a lot of children have sensory issues and they feel things kind of deeper, louder, faster than we do. Same kind of thing happens. So sometimes running water that feels amazing to me, you can't get me out of a shower. Doesn't feel so good to somebody else. So you have to kind of be a detective and figure out what are the things that are bothering this person about this activity and how can I address them? I mean, sometimes it's putting a heater in the bathroom, you know, or sometimes it's maybe making a little change to the routine where we leave a robe on until the water is set at the right temperature. And then we take the robe off when the water's warm and they've felt it and they're comfortable with the temperature. And you make them feel in control of the situation that way. So, yeah.
I was gonna ask, is that a situation, if you were responsible for showering someone, you're talking about sensory, does it make sense also to try starting lower? Like starting on the feet and moving the water up rather than shocking, you know?
Yeah, I mean,
shoulders or.
it's a good point because if you start usually with around the face or the head, like if you just start doing this to somebody, which is why we do recommend handhelds, yes, you want to start with a safer part of the body than the face or the head. Get the temperature right. Once they're comfortable with it, then you can start moving up or doing some of the more fragile areas. But certainly you don't want to, and sometimes I don't even wash hair for a while with somebody. I'll just get them used to in the shower, washing your body off. We'll do hair at a different time or get it done at a salon or have it be a separate occasion. But yes, it's a good point. Start slow.
Oh, elder speak. So we know what elder speak is? So it's kind of a terminology of not putting a professionalism. So it's like calling someone like sweetie or honey, but they really want to be called Mr. or Mrs., right? So you can't kind of assume that someone likes it because we think it's a term of endearment, but it really to that person, they might want to be used in their formal name. They might want to always be called Pam or whatever their name is. So it's really important to kind of remember, that a lot of people like to be, have their formal, they want their formal name. So we wanted to make sure that we're careful with using those terms. When
it's
speaking
kind of
to people.
speaking down and also using a certain tone of voice, speaking to somebody like they're a child.
Right.
So
no baby talk.
no, I might simplify the way I speak. I might speak at a little higher tone because that might be easier for them to hear. But what you don't want to do is speak like they're 3 years old, and demean them.
And also use terms, we never want to say, oh, a diaper, right? Or bibs, that kind of stuff. We want to say we're putting a napkin on or, so just, be careful not to use those kind of baby terms. And again, good communication obviously saves caregiver time. And like we said that, their ability to, they don't have that ability to get a lot of those new memories. So it's important to have that good communication. And these are just the barriers, which we kind of talked about, arguing with someone. Again, we don't want to argue. It's about, validating, being careful with rushing while you're speaking. If you've got someplace you got to go, or, that can get them very agitated. Raising your voice is obviously a barrier. Being demanding or commanding, it's all about the tone, right? It's all about your tone and your approach. Be careful, which we, like we said, asking those memory questions. Oh, you remember Danielle? She, my friend Danielle. So again, we do it, but it's just kind of just being familiar with that's a barrier. And try not to offer long explanations. Again, they're, cognitively, they're not able to comprehend a lot of it. So try to keep things a little bit short, concise, and hopefully that will allow for better communication and understanding.
One big one that comes up a lot, actually two points I want to make. One is saying goodbye. So it seems very insensitive if you're a caregiver or loved one to leave without saying goodbye, but it actually oftentimes makes it easier for that person. So sometimes I'll have people, if they're coming to like an assisted living and visiting, I'll say, have your activity, have a nice time. And then maybe I walk with you and the person with dementia. We were all walking together, and then I kind of have you drop back and I take that person on and you leave, because goodbye is really hard and scary. And that's when we see people trying to wander. Also, any symbols of leaving, or going outdoors, like keys, jackets hung by a door, are all mental signals to try to get outside or try to go find somebody. So we want to stay away from those types of things in terms of wandering and in terms of upsetting somebody when we're leaving, because it's sad for them when you leave. So just do it in a discreet way. And remember, 2 seconds later, they're not going to remember necessarily that you were there. Sometimes they will, depends on the stage, depends on the type of dementia. But in a lot of cases, a few minutes later, they'll be on to another activity and they will forget that you've left or that you didn't say goodbye. Okay. The other point I wanted to make was, I get asked a lot, what do I do if somebody asks, where's daddy? So this woman was always asking, where's daddy? And she meant her husband. She would ask her daughter, where's daddy? And he was not alive anymore. So she said, well, I don't know what to say when she says, where's daddy? How do I answer that? So I don't think that you need to bring up that the person has passed away over and over again, because that's what's going to happen, right? You're going to tell them, and then tomorrow they're going to ask where daddy is again. So you're rehashing it over and over again for them. So a better response is, you know what, it sounds like you're thinking about daddy a lot today. You know what, why don't we look at some photo albums of daddy? It just sounds like you're kind of thinking about him. So let's look at some pictures together. And it'll make sense to them, because yes, they are thinking about that person, and you've gotten off of the subject of what happened to that person and more, hey, let's talk about that person and look at that person and honor that person, but you're not telling them that that person has passed. There are circumstances where somebody can become so perseveratory on that issue that with the help of a therapist, you might have to say it to them at some point, but you don't want to be the one to do that on your own. You should seek advice on how to do that with somebody. There are a few cases where we've had to say, daddy did pass and it's okay, he's happy, or however you put it, but you got to be careful which clients you do that with, because it can be extremely upsetting to them.
Some of these things we actually have already discussed again, and these are some, approaches to take. You always want to use positive phrases, speak slowly, use an adult tone of voice, which we talked about, use, things that are familiar terms and words that are familiar to them. Any sort of, if you're asking them to do something, try to do it in simple task instructions, kind of break it down. We don't want all these multitasking things. Ask one question at a time and then wait for that response. And we said that response could take up to 90 seconds for them to get it, process it, and verbalize it. So don't just assume they don't understand what you're talking about. Sometimes if you're in a room and you're trying to get something done, you don't realize that there is something that could be distracting to them, right? So there could be a buzzing, there could be a radio, so be aware of those kind of things. Or if someone's outside blowing leaves, right? That could be very distracting. So if you're trying to get something passed, kind of be aware of what's around. And like we said, make sure you're including the person in any sort of conversation. Don't talk about them in front of somebody else. Because again, they are understanding. There's many things that they would understand, and you want to make sure that they're included in those conversations.
Even somebody nonverbal.
Yeah.
So if I'm working with somebody nonverbal, I'm gonna make eye contact with them when I'm talking. So let's say I'm getting a little bit of history from the daughter, and this is her father. Okay, I'm still going to be looking him in the eye, asking her questions and saying, okay, so I understand that you like to listen to classical music. That's wonderful. So I'm talking to him, acknowledging him as if he's part of the conversation, but I'm still getting the information from the daughter, but I'm just doing it in a way that's more respectful of the fact that he's right here in the room. So there are ways to do it without completely ignoring the person. I see that a lot, unfortunately. And even, I mean, doctors do it a lot, to be honest with you, because they're trying to get the information fast. So they're going to want all the information from the daughter. And then he's sitting there being completely ignored, and understand that he's might be comprehending a lot of it. And it's upsetting to him that somebody else is speaking to him for it. So I talked about this a little bit. This is important pretty much at any level, but certainly when somebody gets into that more paranoid, agitated level of dementia. Okay, so when you're in those middle stages and they're not trusting of anyone coming in their room, and maybe they've had some bad experiences, or maybe somebody handled them a little too roughly. When you walk in the room, you got to know that that person is not seeing you as the friendly therapist that you are, or the friendly caregiver that you are. They're seeing you as a potential threat, right? Especially if they don't know you, but even if they do know you, because at a certain stage, they might not recognize you, right? Even if you're a family member. So you're always going in trying to develop a relationship of trust, and that it is their space. You are entering their world and their space. So it's a very humbling situation to be in. You really have to put yourself last when you're trying to communicate or work with somebody. And we'll talk about when you have to put yourself first. But when you're trying to have a conversation or work with that person, they have to come first. It cannot be about you in that moment. What I usually try to do is I will look around if I'm working with somebody new and try to find symbols of maybe what their religion is, maybe a hobby, maybe a picture that shows what they did, or an award that they won, or, you know, a plaque that says, you know, MD or fire person or whatever. I'm trying to find clues to who they are. And I'm also trying to get that information from family. So if you treat it as a one size fits all, you're not going to get anywhere. And losing something to one person might mean something totally different to somebody else. So when a certain person loses their car keys, who drove all the time, what is it going to mean to them when their car keys are taken away?
Gee.
Complete loss of independence.
Yeah.
Right?
Yes.
But if somebody didn't drive and lived in the city and was taking trains everywhere, keys aren't going to mean anything to them. You know, that's going to be a different symbol to them. So it's really important to know what that person's about and why they might react a certain way. Okay. Trying to reduce background noise, we talked about. I forget a lot just how distractible people are. So right before I came here, I was working with a gentleman, and we were sitting in a dining room, and there were like 15 people in the dining room. He was at a table with 3 other women who were making a lot of noise, and he was trying to eat. And this gentleman had no what we call initiation, which means he didn't know where to start. Okay, so the spoon was there. He eats with a spoon because that's easier for him, and we made that accommodation. The food was on his plate. There was a ton of food, which I knew he wasn't going to eat all that. So right there, I said, please, let's limit it down, make it simpler for him. But the noise level and the visuals in the room were distracting to me. Like, I think I would lose my appetite. So he's sitting there, and a staff member comes up to me and goes, oh, he's a feed. He's a feed. So that means that He's somebody that you have to feed. He won't feed himself. And I said, oh, really? I was with him the other day. He's not a feed. First of all,
Also, a
he's
term-
Mr. Smith, first of all. Yeah, and they don't mean it. They really don't. I think it's an education component that we have to spend time with staff on. But I had sat with that man 2 days ago, put a spoon in his hand, and he ate half his plate by himself. There was no feeding going on. I didn't even have to touch him. As soon as I initiated the activity for him, he did the rest. Today, he was not doing anything. There was way too much overstimulation going on. And I found out that the last time I saw him, which was a couple weeks ago, I've seen him, but not for a feeding task in a while. Between the time that I had seen him and today, guess what they've been doing? They've been feeding him. So what do you think's happening?
Lots more initiative.
So he's not even knowing where to start. Now he's not even knowing if I put the spoon. I had to do 10,000 more types of cues to get him to remember that process. So, you know, people mean well. They're trying to help him eat and make sure he gets enough nutrition, etc. But now you're taking away his automatic memory, right? So people might forget words. And if I said to him, pick up your spoon, have your dinner, eat your food, he might not respond to that, but people remember the activity of doing it, right? If you take away that activity for too long, the person forgets how to do it. They forget the steps. So same type of situation. I walked with a guy into the bathroom and he goes to the grab bar and I said, do you have to go to the bathroom? And he said, I don't know. And I said, okay, can we try? Now he's on a toileting schedule, okay, which means that our recommendation is he gets placed on a toilet every couple of hours in the hopes that he's successful and then remembers that that's what he's supposed to do, okay? So we walk into the bathroom and the first thing he does is he turns around and he waits. What do you think he was waiting for? Right, okay. And I said, use a different name, Mr. I always use Jones Smith. We need another last name. Mr. Daniels. Please lift up your left hand for me. He's holding on to the bar. He does this. What does this mean? This means that he can hold on with one hand and do other things because he didn't lose balance. He's doing pretty well. So then I put his hand on his pants. Guess what he did? He pulled his pants down, right? But because they're doing it for him every time, he's forgetting. So even if your verbal cues don't work, do something to physically remind somebody and don't take it away from them. Now, if it becomes extremely frustrating and somebody can't finish the task, like if he was trying to get his pants down and he couldn't do it and he started getting angry, that's not what you want. But you want to help just enough to get the task done and make him feel like he was in control of performing that task. Because how do you think that feels versus standing there having somebody yank your pants down? Right? So, and the staff will say, we don't have the time. You know, when we come in here to toilet, it takes so much time. And I'm like, okay, so then I got him on the toilet and guess what happens? He had a bowel movement on the toilet, not in the brief. So I said to the staff member, does it take more time for you now to just help him wipe and clean up versus you pulling him in a wheelchair, having him get completely stripped down because he's had a bowel movement in a brief, which takes more time. So we really, for many reasons, not just the time factor, but it's again, not to blame staff because they do have pressures on them and they do have certain people they've got to get to and they're always worried about that. But if we just remember that if we're a bit more patient, whether you're a caregiver or a loved one, etc., that you might actually save time and save a catastrophic reaction, right? By just taking a couple extra minutes. It's going to end up being better for everybody, I promise. And I am convinced this man does not need to have an accident. He's just forgotten and he needs to be reminded. And what you do is you track the times. What times does he go? Because some people are very regular. He happens to be very regular. That's why I scheduled him to that time. Because I knew he was going to go. Right? So it's kind of being a detective, figuring people out and having the patience to work with people. and not take away, we call it a learned dependency. We don't want to have people learn dependency. We want to keep their independence as long as we can. Demonstrate things with gestures. So I just showed you, like I put his hand, you might have to do tactile cueing. I put his hand on his pants. I might have to not use my words as much because somebody's not comprehending them, but they'll understand if I put their hand on the walker that I'm saying, put your hand here before you stand up and your other hand here. I might have to move their parts because once you start giving body directions, people are not understanding that. They don't have that body awareness. So if you're giving them verbal cues around that, it might be confusing. So it might have to be gestures, or it might have to be what we call hand over hand. Praise non-verbally through nods, caring smile, a rub on the back. I do that all the time. If I feel like, and for little things, like let's say, you know, you've just been struggling to get your wife to go out with you that day, just for a walk around the block. She's fighting you, fighting you, fighting you. Even if she takes 5 steps out the door and comes back in the house, you're gonna be like, honey, that just made my day.
Well, that happened,
just said it.
it happened, she said, I wanna go walk. Okay, we'll go walk.
Yeah.
She went, it's like, kind of, maybe 300 yards. I says, I'm done. I says, oh, great. We came back and I did tell her, I says, oh, it's nice to walk with you. I
That's
said,
perfect.
but that, you know, but that took, you know, with all the other mistakes I've made, that was, I says, this was great because you walked.
Yeah.
She took the initiative to do it, and I just said, I'm following you. Mind if I
You're
go?
just going with her. You went with the flow. And so I just want to tell you, you're saying like you made a lot of mistakes, but a lot of people don't get to that place. So that you got to that place and that you treated her that way, a lot of people can't get to that place, and that's awesome. So you got to pat yourself on the back when you do stuff like that, because that's hard. Right?
I don't know if it was like automatic that where I couldn't process it in the sense that, oh, she must go walk. I think the way I was processing, like, I want to make sure she gets back home. She wasn't doing it.
That's fair.
Okay, I'm thinking like, okay, because there were times when she
Yeah.
knocked at somebody else's door, so I'm like, okay. It's almost, I don't trust this, so let me figure out. And we were able to walk, and she came back home, and the next day, yesterday, she says, I'm going walking. So you know what? I'm gonna see what happens. She went walking for about 10 minutes, came right back in.
Do you have a GPS tracker on her?
No, not yet.
We'll talk about that later.
Yeah.
We'll talk about all the equipment that will help with stuff like that.
And what you said, where you're kind of the next day, you're trying a different approach, that's this. And sometimes you have to like, if they can't get something done, like start over, walk away, come back into the room and try a different approach, and you might be able to get them to, so it's important to do that. We'll start to, yeah.
Yeah. Window of lucidity is those moments where you're gonna look at somebody and say, you know what, it's so weird. Like I was talking to mom today and she made total sense. Like, what the heck? Is she coming back? Is she doing better? And I always caution people, do not have false hope. That's a moment of lucidity. It does not mean that, you know, they've been misdiagnosed and they're actually don't have dementia. There are moments of lucidity where somebody that's nonverbal can say whole sentences. I just had it happen with somebody, totally nonverbal, and she just said a whole sentence to me. It's going to happen. What I say to when those moments happen is enjoy them with that person. If they are clear and they want to talk about something and all of a sudden they're remembering something that they didn't before, just enjoy that moment with them. Hold on to those moments. Stereotypical language you'll see start happening with people in the early to mid stages where they can't think of everyday language. So things like easier said than done, or catchphrases, you got me. Those types of phrases are going to be easier to spit out than to come up with a mixture of other vocabulary that's stored somewhere else. Okay. Empty speech is when somebody will say, you know, you just put that thing here because they can't remember the name of anything. So again, these are kind of red flags. If you see people starting to do that, we all do that sometimes. We all have word finding issues. But if the stereotypical talk starts to replace regular language, that's a bit of a red flag. Paraphasia is confusing words that are related or say the opposite of what they mean. So this happens a lot with he, she. Somebody might call a he, a she, or might say it's too hot, and what they mean it's too cold. So that's where you have to be careful and make sure that you're understanding what they're really meaning, because if water's too cold or too hot, you could be getting into a safety issue. The end stages of dementia, we just want you to be able to recognize that during the end stages, things like the ability to move start diminishing, but also the ability to speak. So we talked about people not being able to make their needs known. So at that point, you're going to start looking at body language to try to figure out what somebody wants or needs. So if somebody's fidgeting a lot, you're going to go back to, are they hungry? Are they tired? Do they need to go to the bathroom? Ask your basic questions first and try those first, because usually it's going to be one of those things. At this point, they're going to need help with most, if not all, daily activities such as eating and self-care. So this, at this point, you may have to help somebody with feeding. They may forget even the process, and that's in the later stages. And difficulty swallowing usually happens in the later stages, which should trigger an assessment, because now people can become at risk for aspiration.
So we talked about this, but this really during the late stages, nonverbal communication is key. And it's, remember, they're trying to figure out you just like you're trying to figure out them. So facial expressions are so important, really making that eye contact. Like Daniel said, those gentle touches, the tone of your voice, your body language is so important. And just remember that your mood is contagious. If you come in a rush and all flurried, they're going to sense that from you. So really, if you, especially in the end stages, really try to come in calm and slow approach, and really make that eye contact is so important.
And at this time, positive sensory experiences can come into play. So we were talking before about how some sensory issues make people uncomfortable, but you can also use sensory in a positive way towards the end stages, because now language is gone, maybe partaking in activities has become too difficult. So at this point, we might give somebody a soft blanket to touch, or you'll see somebody that was a dog lover that might have a stuffed animal and they're stroking it, or sometimes we'll see people holding a baby doll because that brings them comfort. Those are all sensory type items that bring back joyful memories from their past. So those items are chosen specifically for that reason. And then your goals, towards the end stages are going to change. So instead of like in the early stages where you might try to be using memory strategies to help somebody, and the mid stages where you're trying to just be in the moment with that person and keep everything calm and cool. At the late stages, you're looking at comfort care, maintaining dignity, supporting the family, and palliative care. So the palliative care piece and hospice piece is often discussed too late with people. If you have somebody that's diagnosed, you could be a very long way off from when they're going to be on hospice or palliative. Alzheimer's, you could have many, many years before that real big decline.
Actually be on palliative in mid stages and early stages.
Yep, and then hospice, you're talking towards the later stages when somebody really is starting to lose the ability to move, or have any quality of life, because now their illness is kind of taking over everything that they do. But up to that point, really, and even at that point, we're still offering quality of life. It's just recognizing when it's best to kind of back off and let the person be comfortable. And it's a different type of care that's offered at that point. We have hospice programs and palliative programs that come into the home. There are other programs that are out in the community in facilities if people are more comfortable with that. But I've been with people progressing through all stages till the end, and you can do it at home, and you can get through it if you have the right resources and if you know when to give yourself a break and to get respite for yourself as a caregiver.
And then just in closing, again, people will forget what you say, people will forget what you did, but they'll never forget how you made them feel. So that's really at those end, stages too. It's just all nonverbal and everything you could do to validate and connect at that point.
Questions? Comments?
So for me, it was,
Good.
knowledge of what I have to now keep adjusting to what I find, I made some mistakes or whatever, that every day is different.
Mhm.
One day, okay, I'll go off to make it simple for me. Okay, this is green today, maybe it'll be green tomorrow.
Yeah.
Maybe red, and now I says, okay, it's red, so I have to file away adjusting and I have a hard time trying to figure, by the time I figure that out, I said, okay, red will be tomorrow. No, now it's orange.
So what you can do to help with some of that is to create routines that are pretty distinctive as much as possible. So the same wake up time, the same order of things if possible. So breakfast at a certain time, maybe after lunch, an hour later, you do an activity, and then you have a tea time, or, just things that the person are going to start to get ingrained in their system is going to be the routine for the day, because routines actually bring down their stress. If every day is kind of a mystery to them in terms of what you're going to throw at them too, because you're more flexible, you're a higher functioning person cognitively, so you can start your day doing things out of order. They can't be as flexible as that.
See, that's the interesting thing. Then what this routine, she was structured. She did this, and she still does, like early in the morning, get up, take my blood pressure medicine, then I'll do exercise, then I'll do this. I don't even, she does it on her own. That's her independence, so to speak, what she does. And now it's become with some days it's back in the same routine, and some days it's no routine for. It's like it shifts. So it's kind of difficult for me to figure out how do I, I really did this or I really did that. And I know she didn't do it, but I don't know what do I tell her? I don't know, because she's always been structured. I mean, it's like her structure, her routine was like, she was the lead person or the type A person.
Right.
I'm the follower, so to speak. She's gonna say, we're gonna do A, B, C, D. Okay. And now it's, some days it's A, B, C, D, and some days it's E, D, E, F. I don't even know what it is, so as a certain time she gets up. Now
it's all over the place. Try to take some of the ownership for that structure. And you're not always going to win, but if she used to get up at a certain time, I would still try to have her get up at that time. And if she rejects you, what do? What are the strategies if she says, no, I'm not getting up?
I'm just saying, I guess, okay, I don't know at that point.
Walk away,
Yeah.
come back. Okay. Try a different approach.
Are there any questions on Zoom? So make sure we didn't miss anyone.
They just said this was very helpful. We have a copy of this presentation. I'll just let them know.
Right.
Thank you. Anybody else?
Thank you all. You have any other?
No, this was.
I hope it was helpful.
Our next,
She said. Would that be your mind? Because my daughter would love to,
The presentation? Yeah, it's recorded, so, but I'm gonna talk to you after anyway, and we'll figure, because you're gonna need more than just this right now. You know what I mean?
No, I know that.
and our next presentation is home modifications. So that you might need for a dementia family home, friendly home. So The owner of On the Mend is gonna be bringing some of what he has, and Melissa Woodhouse, who's our other OT, and the director of Staywell Department is gonna be presenting some good DME, some durable medical equipment and stuff that you may need in your home. So that is on May 16th at 1 o'clock right here as well.
My mother left Isabel. I don't know if she's still around. Isabel.
Oh, Isabel.
Oh, she was great. The age,
Yep.
I think she went down south.
Yeah,
She's great.
it was great. Yeah, she went down south. Last year, year and a half ago. With her-
She had the right approach.
Yeah. She did.
Sure.
I'm noticing like, there could be a problem, he's trying to solve a problem. And if I give an answer, but he's not taking it and he will focus on it. And it'll lead him to do like either to go to someone else, like for example, there was an issue, something happened with his banking. Which we're moving totally away from that now, but. And it's at work, and I thought I understood, I thought it was a confusion, the bank had sent out a notice, they're changing how they name the checking account, and he thought. Something was happening to his checking account. And so I explained what it was, but it wasn't good enough. And then I said, well, then I thought, I bet he went in and he used his password incorrectly.
Got it. Yep.
But he had to go to the bank. Like, I couldn't stop him from taking all these other steps.
Fixed it.
He just, the focus on it, and it didn't matter what I offered as an explanation for the problem, and it turned out it was that he'd gone in too many times and got shut out. But he went to the bank. I don't know what happened there, but he said they couldn't help him.
Is that before he came to you or after?
He did it after he came to me. He went, so I was still at work and I said, I will, when I get home, I think if it's not this, if this is what the problem is. But he couldn't wait. He couldn't like.
Yeah, no, I
allow
understand.
time. He,
Is he alone? Was he alone at that time or somebody with, yeah, see, that's when the judgment starts to go to a point where
he's got to fix it right away.
the judgment's off and you have to be a little bit careful